As we prepare for each exam, let's go over some basic exam test taking tips. We always want to read the question carefully. You want to identify the subject or the concept that the question is talking about. You want to pick out those keywords and then ask, what is the question really asking? What is the question really asking? You want to read each answer carefully. Remember that only one answer is the correct answer if it does not say select all that apply. Think about what is the desired outcome for the client. You want to think about health and safety. Then remember your scope of practice. We are PN, so remember your scope of practice. Priority questions all answers may be right, but at least one is the best. Think of it only do one, if I could only do one of these, which is the safest and the best for this client right now. Okay. So again, for priority questions, all answers may be something, an intervention that we can do. It might be a correct response, but it's telling you to select one. So just think, if I can only do one of these, which is the best and the safest intervention for this client? Okay. Um, Questions you want to, as you read through your questions, you want to think about, are these expected outcomes for what is the scenario that's being discussed? Is this client stable versus unstable? Is this a potential risk or is it a real risk? Is it expected or unexpected, or is it chronic versus acute? So then going back to priority, think about airway, breathing, and circulation. Is what's going on in this client going to put them at risk? Is it going to put the breathing, the airway, breathing, and circulation at risk? Is this client potentially unsafe? Is this client potentially going to die first? If I don't complete this intervention, is harm going to come to this client? If airway, breathing, and circulation is not a concern, then go to Maslow's hierarchy of needs. Then go to that bottom level, those physiological needs. Okay, so all of these are test taking tips. Remember to have both your devices, your chargers. Make sure you have your ID, your dry erase board, or that clear sheet protector, or you can even use a Ziploc bag because it's the same thing as a clear sheet protector. Okay. To prove minimum competency, a beginning nurse must demonstrate ability to make appropriate nursing judgments. So just keep that in mind as we review our concepts here in just a second. We need to be able to recognize both expected and unexpected outcomes. Outcomes allows us as a nurse to evaluate where the goals have been met. Okay. So let's think. As we are looking at the nursing process, we have the registered nurse and the LPN. Okay. So we have ADPOT, assessment. That's what we're gathering data independently. Both the RN and the LPN, they're doing this independently. This allows us to provide that culturally competent care to our clients, because hopefully during that assessment phase, we are establishing those therapeutic relationships with our clients. So hopefully we can advocate, because remember, client advocacy is a key role for us. The client's need, for us to advocate is there, especially if this, whatever's going on with them is new to them. So we have to advocate to ensure that they uh, have the opportunity to be informed as much as possible. Okay. All right. So doing the diagnosis, the registered nurse does this. And the registered nurse will use NANDA, those nursing diagnoses, to pull up that information. Okay. So doing the Planning phase, the RN and LPN, they're collaborating during this phase. And then implementation, what are we going to do? What are those interventions that we will implement or will carry out? Both of us, the RNs and LPNs, we both can carry out those orders independently. For example, we can administer medication, we can do that dressing change, we can carry out those orders independently. And then we have our last phase, which is evaluation, that last part of that process. We are doing this phase, we're reporting our recognized findings, okay? And then we're going to determine whether or not what we planned for, implemented, did it work? Was the goal met or was the goal not met? Okay. Okay. This is just another view of looking at it. The LPN functions more independently doing that collection process, that gathering data. Remember that the RN creates a nursing diagnosis. The LPN and RN, they collaborate on that plan of care. Remember, safety is priority. Both the RN and LPNs can administer medications under the direction of a healthcare provider with that prescriptive authority, okay? Both the RN and LPN, we both can delegate to unlicensed personnel, but we do want to ensure that whomever we're delegating it to, that it is appropriate for them, that it is in their scope of practice, that they have been checked off on it, or it is approved for them to actually complete that task that we are delegating. So of course the RN can delegate also to the LPN as well. Okay. And it's going to be based on that. After we go in and assess that client, what are their needs? And then it's going to be on that staff's competency. You know, the RN more than likely is not going to delegate some tasks to a new LPN as well as especially if they're not checked off or it's not part of their competencies. It's in their scope of practice, but it's not on their competency checklist to say they can perform those. Okay. So the LPN, we reinforce that teaching. We reinforce that teaching. Okay, let's go back. So when collaborating with the RN, the plan of care outcomes should be measurable, realistic, and time specific. Okay. When we're talking about the subjective and objective data, this is going back to that assessment phase. Remember, the subject is that patient, that client. Depends on what setting you're in, is what we call them. But nevertheless, is that information that they are telling us. Okay. They're telling us this. We usually get this information during that assessment process. The RN is taught that more in-depth assessment skills, and they do that more comprehensive physical assessment of the body systems. Okay. So um, critical thinking and clinical judgment are both ways of solving, creating a solution to whatever is going on. So there's a way that we can critically think so that we address everything that the client actually needs. So that's collecting data in an organized way, verifying that data. Then we want to arrange it. When we arrange it, we'll be able to look to see if there are any gaps in that information. Then we have to analyze it and step back and say, well, wait a minute, what are we looking at here? And then we're going to test it out. But remember that critical thinking is nursing judgment, the nursing process, that API, that critical thinking. These are both things that we use to solve problems. Okay. Critical thinking is based on the principles and the steps of the nursing process. Okay. And on that scientific method. So it's not something that we're just haphazardly pulling out of the sky. So, for example, making judgments based on evidence, facts rather than guesswork. Yes. So it's evidence that's guiding us. Okay. Now let's look at some examples of critical thinking. We're noticing that change in that client. Altered mental status, change in blood pressure, it can go up or down. Even when we're questioning that medication order, if the dose is unusually high or low, just an unusual amount, just question it just to make sure. Because we're critically thinking, say, wait a minute, going through our files, this is not the usual dose. So prioritizing that patient care, we want to be adapting to unexpected issues. So, for example, the oxygen delivery system failure, what do we do? That concentrator, is there a nearby oxygen cylinder? What are our steps? And determine that a pain medication is not adequate for a post-op client. If that client is consistently complaining of pain, they may not ever be pain free, but they should be in less pain. So when we reassess, what are our findings? The nurse must use clinical judgment to interpret the patient's unique situation. We want to consider all that is going on with that patient. Okay. So these are some ways of that we're thinking and processing information. Knowledge. What are we recalling? Is it lab values, comprehension? What's our understanding of the content and our foundational knowledge? Application, using what we know. For example, the blood pressure that we're getting, there is an abnormally low or high number. We want to verify that information. We may have to actually check that blood pressure manually just to verify. Analysis is when we're breaking down that complex information into basic parts. Remember, we said that, being that client advocate, breaking down and identifying the subject or the concepts that's in that question. What is the question really asking you? Okay. Remember, critical thinking, it involves all of these levels of thinking. Purposeful, evidence-based decision making. We're assessing the client. We're considering that nursing process, and that's those scientific principles. Okay. All right, so now let's put it all together here. We're recalling what the potassium level is, comprehension. What does a high or low potassium level mean, or high or low blood pressure? Application, what do I do with this information? How do I take care of this client? Because we want to, as we critically think, we want to provide that optimal patient care. We should, as a nurse, be applying the knowledge and skills and experience that we have to improve patient outcomes, which is at that core of critical thinking. We want to be observing, analyzing, and applying and planning all along. It's just a fluid process. Okay. Okay. So Tanner's model, think about it. We're noticing that subtle change in that client. That client, even if it's, no change is too big or too small. The client usually eats breakfast. That's usually their better meal, but now we notice they're not eating any of their meals. We notice the client usually is engaged on activity sessions. We notice that the client isn't as engaged or not attending activities. So what does that mean? Let's move on to interpret it. What's going to be our response to this? We're going to do dietary to go in to reassess their eating habits. Do we need to call does this person need to go to the dentist? So once we notice, Tanner gets us to look back and say, okay, what's really going on? What are we noticing about this patient? And there's no change, too big or small, to be addressed. Okay. So before we go any further here, let's go back. The nursing process is a systematic approach used by nurses to provide high quality care. Remember, and we're analyzing, we're assessing that, looking at that data. What is the patient's problem? We're developing that plan of care because that's going to be the guidelines, our steps to executing whatever that plan of care, those interventions are for our client. And then we want to make sure that we're assessing, is this working? Is this working, the interventions that we have decided upon? Okay. All right. So ethics is a system of standards, system of standards, or moral principles that direct our actions as being right or wrong. Ethics is concerned with the ways people, either individually or as a group, decide the following: what actions are right or wrong. If one has the right to do something, okay? If one has the duty to do something, is the duty goes back to, is this part of the patient's care plan? Are they, is it my duty, my task? When I was given this assignment, is it my task to ensure that these things are completed and done for this patient? No, is it my duty? Personal ethics can provide personal guidelines for living. You ultimately choose what your personal code of ethics include. Your personal code of ethics will influence your nursing ethics. Sometimes personal ethics conflict with the State Nurse Practice Act. So, what does that mean? Professionally, the nurse state, my scope of practice states that I can lawfully complete whatever the task is. But personally, I might not feel comfortable completing whatever that task is in the setting that I work in. Okay. So that's when we would, go to our supervisor and discuss whatever it is that we're having an issue with personally. Because remember, lawfully, professionally, we can complete those tasks. All right. So that's an extra conversation that we would need to have. So we're establishing those therapeutic relationships with our clients, and we are wanting to provide culturally competent care. We want to be culturally competent. So that involves learning about and respecting the things that our patients value, what they value and want to include in their care as well. Okay. We want to be advocates for our clients, and this means that we're advocating that the nurse is the key person that will be advocating for the client's needs. Okay. Accountability. The word accountability means that you are answerable to yourself, to your assigned client, and their family. Sometimes they do have power of attorney, so that's a legal document. And so we have to, respond to and communicate with that family member. Client safety reporting. That this includes reporting the peer, supervisor, any team member for behaviors that are potentially harmful to the client. Okay. Systems-based issues. We want to identify system-based issues. This is going to be essential in providing safe, high quality care. So, because if something's going wrong with the process that we have in place, we need to go ahead and identify that and do something about it. Let me go back to this personal and professional ethics. Sometimes, because of this, we might experience moral distress. It occurs when a nurse knows that ethically correct answer or action, but feels powerless to act due to institutional or legal constraints. So that's another part of that, because personally, you know the correct thing to do, but then you just feel powerless. That's what we call moral distress. So we do have some ethical principles here, and we look at non-malfeasance. Okay, that is to do no harm. Beneficence is what we're going to do. Is that going to benefit this client? Okay. Autonomy, free to choose. This includes privacy. The client is free to choose, free to refuse care. Okay. Fidelity, we want to be true, making sure that we follow through to whatever it is that those interventions and things that we've conveyed to our patients that we're going to do. Justice, treating everyone fairly. And then veracity, just being truthful. Being truthful. Okay. Okay. Beneficent paternalism is really the opposite of autonomy. It is having that disrespectful attitude toward the client and what the client has contributed to their personal care and recovery. Beneficent paternalism is almost like having I know what's best for you attitude. Even though the patient or the patient's responsible person has made a decision, the healthcare provider comes in and say, nope, I know what's best for you. Usually you see this in emergency situations. This is not something that you run into every day. Now, it does not mean that the courts will side with the healthcare provider, but it does allow the healthcare provider to present their information further. Okay. As nurses, we have a legal responsibility to report any professional whom they suspect or they know that's engaging in, going back to his colleague reporting, in illegal or immoral or unethical activities. So failure to report these acts is a direct violation of the ethics code. Okay. Okay. So the state statutes that apply to licensed persons in situations in client care that could result in legal action. Where can we find them? We can go to our professional groups. They're professional groups that we can belong to. You know, the LPN has several groups. Our state nurse practice act. So whichever state that you're residing in and that you're licensed in, you want to refer to that state's nurse practice act. Okay, where can we find those mental competencies in that state nurse practice? And they're specific by state now. And it's important that we know what our scope of practice is in whatever state that we're practicing in. Okay, because we don't want to be practicing unlawful. Okay, so this is what's actually located. This is the content that's in that Nurse State Practice Act. Okay, how much continuing education do we need in order to continue to have our licensure? Okay, what are our responsibilities? Okay. They have the National Association of Licensed Practical or Vocational Nurses. This is where it explicitly says that the LPN are expected to maintain patients' confidentiality. Okay, so this ethical principle is fundamental in nursing practice. It's consistent across various nursing codes of ethics. Okay, maintaining that confidentiality. Where that's going back to a slide here. It's crucial. We have got to maintain that confidentiality. Okay. So this slide right here is just breaking down the state boards of nursing functions. Now, this is a group of people that assemble, and these are the things that they address. Okay. If a complaint is filed, it goes to the state board. The state board looks at that complaint, an investigation is done. Board proceedings. This is when the nurse has the opportunity to respond to those board proceedings. Okay. Okay, then the board action. Can be where, they can decide, if an emergency action should there be immediate suspension. Disciplinary action should the nurse be fined with monetary. Should there be remediation? And also they place the information inside of these databanks. So going forward, employers can look in these databanks and see if there are any disciplinary actions against or on this nurse's file. So this database, they have a nurse's license verification, and it's a different site than your state board. They go into this database to see if the nurse is licensed and see what that license number is, has it expired, and to see if there are any disciplinary actions listed there. Okay. So liability is being responsible for something. Liability in nursing is associated with the civil law, and it includes contracts, negligence, and intentional and unintentional torts. Okay. So it's going to be so important that we put into practice all of those, those safety checks, those safety measures that are there. They're there to protect us. Stopping to ensure that we, um, do our medication administration rights, ensuring that we verify who that patient is prior to giving those medications or performing care on, ensuring that what their code status is, you know. So legal liability, in the event that we are found liable, it can lead to um, jail time, prison time. It can also lead to having to pay monetary compensations. Okay? So intentional and unintentional. An intentional tort is intended to cause harm to the client or actual physical harm. An unintentional um, tort is when the nurse did not mean to cause harm. I did not mean to hurt the client. But it's no defense. The nurse gave the incorrect medication and it caused injury. The nurse didn't intend to, but the nurse didn't follow those medication administration rights. So we want to ensure that we are not negligent. We want to ensure that you remember, negligence is failure to act as a reasonably prudent nurse would. Okay. A tort, we talk about these torts, is a civil wrongdoing that causes harm leading to legal liability. Okay, so when negligence, again, is a failure to act with an ordinary care and injury is caused to another. And these are the four components that they look at. They're trying to prove that negligence actually happened. Was this client or patient assigned to the nurse? What did the care plan say that the nurse needed to do to take care of this client? Did the nurse complete the care as outlined in that individualized care plan? If they did not, that's a breach of duty. Okay. Did the client sustain damages? And then there's proximate cause. When they go back and look, they say, well, hey, is there a direct connection between the injuries that this client sustained and the acts that the nurse didn't do? And if there's a direct connection, then yes, it is deemed as negligence. Okay. All right. So malpractice is a type of civil violation. It occurs when the nurse fails to meet the accepted standard of care, resulting in that patient's harm. Okay, that's malpractice. All right, let's look at it here. So battery, that's to cause physical harm to someone. And then assault, unjustified attempt or threat to touch someone. Okay. So let's look back at battery. That's performing a procedure without a patient's consent. Go ahead. An example of assault is threatening to give a patient medication. Even though the client doesn't have a medication for them to sleep, but they may have a pain medication that will cause them to be drowsy and the client's hollering out or not going to sleep as normally during the hours of sleep. And we threaten to give that medication to put them to sleep. We're threatening to give that medication with an unauthorized use. Okay. So assault is that unjustified attempt to threat or to touch someone. Right. So when we look at, okay, all states have mandatory reporting laws for abuse. As nurses, we are obligated to report suspicion and confirmation of abuse. So look at these chemical and physical restraints. Chemical restraints are medications. That's an example that I just gave about the nurse threatening to give the client some medication that will, put them to sleep because the nurse is wanting the patient to go to sleep and start ringing the call light. A physical restraint is an example, is a wrist restraint. Now you really don't see these restraints much anymore, but they are such a thing. Wrist restraints, desk restraints, they're all different kinds that are out there. Okay. So libel and slander. Let's look at these. Defamation, damage to one's character can be through slander, spoken, or libel, which is written. Okay. What are some examples of libel? So libel is written, sent in an email. So be careful what you're sharing on these emails, or the Facebook and all those different things. That if you're sharing messages, make sure the information that you're sharing is not damaging to one's character. Posting on social medias, false accusations. All right. So defamations, damage to one's character can be through slander, which is spoken, or libel, which is written. We talked about is the nurse's responsibility to keep a client's information private. Clients have a right to have a copy of their medical records. But as a nurse, we must adhere to that minimum necessary rule to protect the client's privacy. The client's name, address, and payer information are appropriate for the nurse to disclose to, like, for example, a vendor. Okay. For example, this client is getting some medical supplies, but any other information is not needed for that. That vendor shouldn't have to have that information. Otherwise, we're violating HIPAA. The client has a right to consent, saying, yes, I will have this treatment, and they have the right to say, no, I do not want this treatment. They have a right to choose. Okay. Informed consent, we must obtain it for invasive procedures. You know, informed consent means that the client is told all of the following in non-medical language: their diagnosis or suspected diagnosis, the purpose and description of treatment, expected outcome, expected benefits, and possible side effects of complications, explanations of alternative treatments, their benefits, and also possible side effects. They should have the names and qualifications of the people who will perform the procedure. Prognosis, answers to questions the clients won't clarify. Explanations that the client has the right to revoke written permission at any time. The client could be on the stretcher, getting in the elevator, going down to the OR, and they can change their mind at any moment in time. Okay. So we don't want to tell a patient they cannot leave the hospital. They want to leave against medical advice. We make them, aware of everything, and they can make that informed decision. So we do have legal documents. Living will describes the kind of medical treatments or life-saving treatments the person would or would not want if seriously or terminally ill. The living will does not specify a person. Okay. So the Durban Medical Power of Attorney, it is a legal document and is valid in all 50 states. It names a person, anyone at least 18 years of age, to make those medical decisions for them. The living will does not specify a person, but the medical power of attorney, it does specify a person to make those decisions for them. And the do not resuscitate order, advance directive based on the Patient Self-Determination Act that gives a physician legal permission to write such a order.